All right, hi everybody. We're just going to give it a couple more minutes before we get started here as we get people kind of joining in. This is Dr. Wong with the Clinical Pattern Recognition team. I just drove in from Anaheim from our Protection of Human Subjects in Research meeting. So a lot of really geeky people talking about really cool, important things. So it was a really cool meeting. And so anyways, there's one of the cool things that they have at this meeting, of course, are these little flags that you guys all remember from your little conferences. CSM has them. You know, a lot of different people have these little different badges you can see here. So IRB chair, this was the meeting that we were at. But most importantly, as we come into this conference, my goals for our short time together this evening is to banish chaos and get smart. It's my favorite little banner from this meeting this week. So we spent the last 4 days learning about human subjects research protection. So anyways, I want to welcome everybody who's joining us this evening. This is Dr. Wong again with the Clinical Pattern Recognition team. And my hope, my goal is that we'll be able to enjoy some time together. We'll play a case out together, and we'll get some interaction. Really what I want to talk about is managing conditions like spine arthritis. Okay, so why don't we just get started here. First, a couple of key questions, a few questions for you guys. So in your programs, in your orthopedic programs, do you have several quarters or semesters of orthopedics where examination and treatment are in separate quarters? So you learn about examination in one quarter and treatment in another quarter. So are there any of you out there who have this kind of experience where your orthopedic classes are separated, meaning interventions in one quarter and kind of investigation or kind of your special testing examination is a different quarter? If any of you are out there who have that, give me a thumbs up. Let me take a look at how many of you have those kinds of classes. Okay? All right, so let's take a look here. All right. We don't have any responses yet. So think about this, right? A lot of the content that is being delivered in your classes are being delivered in small pieces. This is what we have to work with. Every professor has to work with that. So the next question I have for you is, do you ever feel like there's tons of material, tons of content, special tests, treatments, manual therapy, exercise, pain sciences, pathologies all over the place? Do you ever feel like there's a disconnect? It's difficult for you to pull all those pieces together. Right? So any of you out there who've had that experience where you have tons and tons of material that you're being forced to memorize and to learn, but feel like it's very difficult to connect the dots. So anybody out there who has had that type of experience, right? Give me a thumbs up, give me a okay sign, just so I can see if you guys have had that type of experience before. Okay, so I'm just moving in closer here to see who's posting and who's not. Okay, so from our recent exhibition at National Student Conclave, it seems that there's a very consistent feeling that there's an overwhelming number of techniques, manual therapy techniques, exercises, all of those things really all not connecting well, all the dots not connecting, right? So my goal with you over these next few minutes is to play out a pattern and have a quick dialogue with you, right? What are the kind of things that you would do for this type of patient? Okay? So again, our goal, as mentioned in this little badge here is to banish the chaos and get smart. All right, let's do this. So, all right, so this is your patient. Put your thinking caps on. You're the clinician now. Your patient, me, is a 56-year-old male who's coming in with significant low back pain. I'll show you my low back pain right here. Okay, I've got significant low back pain kind of through here. And with that low back pain, which is about 6 to 7 out of 10, it's basically gradually gotten worse over the years. And so what I'm having a hard time with is bending forward, bending backwards, walking for too long, or spending too much time on my feet. It really makes my back sore. Okay, right through here. I'm going to adjust this a little bit so you can see a little bit better. And my pain pretty much stays in my local low back. All right? So, no particular injury. It's just my back is getting worse and worse over time. So, I'm going to put it out there for you guys, all the clinicians out there. What are your thoughts? Go ahead and type it in. What are the kind of hypotheses that you might have related to this particular back pain condition? All right, any thoughts? What kind of diagnoses, what kind of hypotheses might you have with this patient with localized back pain, right? Pain with bending, pain with extension. Okay, good. Looks like motor coordination impairment. Nice job, Jessica. Andrew, spinal stenosis. Awesome. Right. Anything else? Now, pain is localized. What else you guys got? Okay. Think about this. Is it spinal stenosis if there's no pain going below the leg, going into the leg? Could it be a degenerative condition that is eventually going to lead to spinal stenosis? Very, very possibly. Right? And of course, walking, which reproduces the patient's pain, could be spinal stenosis, except lots of patients who have degenerative spines may also have these kind of conditions, right? So, all right, so you have this patient who's coming in and says, I have problems bending forward, even side bending. What you see as the movement specialist is a person who actually can't get full range of motion, right? So, all right, so with that in mind, what are the kind of things that you would want to do for your examination, your physical exam? So I'm going to open it up to the group here. You think that this might be spinal stenosis or some degenerative spine disease or some kind of stiffness problem. What kind of things would you want to do for your examination, your physical exam? All right, so go ahead and type some stuff in here. Let's take a look. Okay, Jessica says prone instability test. Catherine, SFMA, good stuff. Keep it coming. This patient is telling you that I'm having problems moving enough in life. I cannot bend enough or extend enough. Nice work, Jessica. Active range of motion with overpressures. Lainey is asking which is worse, flexion or extension. Lainey, I would say that range of motion is limited in flexion and extension and side bending. All directions are limited. Yep, Alicia, excellent. Active range of motion, passive range of motion, PAs. Now, what you are doing now is, as a movement scientist, you have observed me, you've listened to my problem, you haven't heard a major mechanism of injury, right? But this problem's getting worse over time. And now you're saying, I can see that you're not moving very well, so I'm going to examine that. Active range of motion, passive range of motion, and accessory mobility. Okay? Perfect. So, let me tell you your findings. active range of motion in all directions were limited. Okay, I'm not going to give any particular measurements. Let's just say they were limited 50% compared to what you would expect for a normal person. Okay, I know that's not ideal, but for these purposes, we'll use 50%. Passive range of motion, equally limited and painful. Patients complaining of stiffness, says, man, in the mornings when I wake up, I feel 60 years old. And I know you're going to say, you are 60 years old, but I feel 60 years old, and so it takes me a bit before my back loosens up. Okay? So, what kind of, if you found active range of motion, passive range of motion, and accessory mobility, right? PAs, you can do physiologic mobility, and what you found was all of these mobility findings are limited. So, what kind of interventions have you learned that you would potentially use for this patient to help this patient have less dysfunction in life, have less disability? So go ahead and, now that you know I have limited active and passive range, limited accessory mobility, what kind of treatments would you guys use? And this is open to all the different schools. What kind of treatments? So, yep, Andrew's got MWMs. Awesome. Peter's got MWMs as well. Jessica, MWMs and PAs. Yep, keep them coming. The patient said, hey, I'm having problems in life. We've got some Mackenzie. So bringing up Mackenzie is not a bad idea. Now, remember, Mackenzie is just repeated movements. Does this patient have movement limitations? He does. So doing repeated movements will probably get his back to move a little bit better. But I do want you to consider, this is Catherine, this is a great thought, Catherine, that typically we use repeated movements and Mackenzie style types of treatments to centralize leg pain, right? So the patient may, in this case, does not necessarily have leg pain, but repeated movements is still a movement, and it will probably help the patient if we choose directions that will help restore mobility. So that, I think that's a good call as well. Okay? So what you've just done is you heard the patient who said, I'm having problems moving in life. I have mobility deficits. And you did an examination of mobility, active range, passive range, and accessory mobility. And you found some positive findings that you went about going to restore. So, sure, I can do some PAs. I can do some MWMs, right? I can even teach the patient to do some repeated movements. Let's say he's limited in extension. Maybe in the beginning, I might choose some type of unloading movement. So maybe I'll do a double knee to chest or a single knee to chest first. In the end, I'm still restoring motion, right, to the joint. And what would be a home exercise program that you guys would use potentially to restore mobility of this patient's lumbar spine? So what do you guys think? We can do some PIVMs. Yep. Absolutely. Get the joints moving, right? Motion is lotion. We're going to get some synovial fluid into the joint. Any other home exercise program things that you might do for these patients? PA on a tennis ball, perfect, right? That mimics our manual therapy techniques. Remember, if the patient had problems, supine trunk rotations, absolutely, right? Because all of these fit into a treatment category of mobility. The patient came to you with mobility deficits, you examined mobility, you treated with mobility, and you gave them a home exercise program with mobility. Yeah. Traction is bringing in modalities, a class that you guys took 2 or 3 quarters ago. Traction is a mobility-inducing treatment. That's good stuff. I mean, that's the point being here, that there's a lot of different treatments that you could do. The fact is, you're trying to restore mobility for a patient who says, I can't move enough, and that's why my life sucks, right? So I think traction is fair game. The only thing about traction, I would say, is it takes time to set up, right? And it takes time. It's not active. It's a passive treatment, and they can't go home with it. So traction is not a wrong answer, it's a time-consuming answer. And it's not really an active approach to rehab. So in this case, I would say traction would be lower on my list. So those are all great thoughts. All right, so here's what I want you to what I want you to think about. Yeah, walking would be great as well. Low back pain, for all forms of low back pain, you've got manipulations. Peter's got manipulations on there. Who else would you do manipulations on than people who have mobility deficits, right? You've got a clinical prediction rule that says there's no pain below the knee, right? He has good hip internal rotation. He has at least one segment of lumbar stiffness and very minimal fear, right? FABQW of less than 19 and pain less than 16 days. I mean, granted, he's probably had pain for more than 3 years, but he still fits at least probably four of the 5. He would be a perfect candidate for manipulation, right? It's in some form, it's a mobilization to the spine. So that's all fair game. All right, so you guys are right on. This is a pattern that the guidelines talks about called mobility deficits, right? Back pain with mobility deficits. Now, if I just put that word out there, you have already put out some pathologies. List for me some pathologies in the lumbar spine that fit a person who's coming in with back pain and mobility deficits. His life is terrible. He has pain and difficulty in life because he can't move enough. So go ahead and just type in a few pathologies, some that you had mentioned before. There are a few that I didn't see, so let's see what you guys got. What pathologies of the spine? Yep, facet syndrome, spinal stenosis. All of these guys are limited in mobility. Excellent. What else? Any other conditions that end up causing a stiff spine? Yep, Catherine, yep, DDD, OA, yes. So think about this, right? You have just herniated nucleus pulposus, Paul, yep, awesome answer, Paul. The problem is most of these painful conditions probably will limit some of the motion of the spine, okay? But if you have a herniated nucleus pulposus, there's a good chance that nerve root's going to be involved, and that will be radiating pain. We'll talk about that in another session. But that is a fair answer. I mean, herniated nucleus pulposus will cause mobility deficits. Most back pain causes some form of mobility deficits, right? So those are all excellent thoughts. Okay, so I'm going to take a moment here, and I'm going to open up. We're going to just take a look at this together into lumbar spine. All right, so we're going into the pain pattern. I had pain on bilateral parts of my low back without pain into the leg, right? So that tends to imply maybe local structures. So I'm going to examine local structures. And here I have my facet joint syndrome or some type of degenerative spine syndrome. So I'm going to take that and look at prevalence of the condition. And what you see is people with greater than or equal to 50 years old. So facet joint as a source of chronic low back pain, that's 31%. Degenerative joint disease, right? So that all kind of fits. And I can watch this patient and how they present, which is basically how I presented to you earlier. And we can look into the physical exam. And just like you guys had mentioned, in the physical exam, the main examination that we would expect you as the student, as the clinician, as the resident, or the fellow to do is actually an investigation of active and passive range of motion, right? Passive range of motion, and your accessory motion exam. These are the things in which you examine to assess whether the patient has enough mobility. I would say also that it's probably valuable to look at the joints above and below, right? Because this is a degenerative problem. So you probably want to do a hip assessment, and you probably want to look at the thorax as well, right? So you can do a quick observation of thoracic mobility, right? Because really, if it's degenerative spine disease, why wouldn't it be degenerative in other places in the surrounding regions, okay? And when we come into the interventions, as you had mentioned, your manual therapy is typically, just like you had mentioned, let's go over here, improving mobility of the spine. You can do your manipulations. You can do your PAs, right? You can do your lumbar snags. And your therapeutic exercises are matching, right? I want to improve his lumbar flexion, so I'm going to do quadruped rock back or double knee to chest. I want to improve his lumbar rotation, so I'm going to do side lying trunk rotation, right? These are all the same things that you guys had mentioned. So, you guys, so it's backwards. Can you flip the camera? I will do that next time. Sorry about that. Now, the main thing I want you to think about as we're closing out this particular session is this idea of mobility deficits. It translates into multiple joints. So, can you think of any other joints where patients come to you complaining that their joint is stiff, it hurts when I move it, I can't move it enough so it limits my life, right? So are there any other conditions that you can think of in any other parts of the body where mobility deficits is the primary limiter of this patient's function? So go for it. What do you guys got? Other pathologies in other joints where mobility deficits is the primary problem. Let's see what you've got here. Hip, knee, ankle, SIJ, shoulder. Andrew, you've got hip OA, yep. Jessica, everything. That's a little bit broad. Hip OA. Peter's got frozen shoulder. Jordan's got hip OA. Hannah, awesome, frozen shoulder. Yep, that's all good stuff. Knee OA. Yes. So, think about this, right? Let's take frozen shoulder, for example. The person comes in and says, I'm having problems in my life because I can't move enough. So in your mind, you're like, hey, I recognize that. So I'm curious, you're saying you can't reach up? I first heard you say identify joints. No problem. So I can't reach back. I don't have enough range of motion. Sounds like mobility deficit, right? Well, the guidelines calls this problem shoulder pain with mobility deficits. Someone who said hip OA, hip osteoarthritis, knee osteoarthritis. They come to you, they're 50 and over, they complain that their hip is stiff in the morning, less than 30 minutes, usually because once they get moving it loosens up a little, right? The knee OA person says the same thing. The elbow arthritis person says the same thing. They have limited range of motion, so they are elbow pain with mobility deficits. Knee pain with mobility deficits. So, what would be your examination? What would be your key findings for these patients? What do you think? What would you do to examine a patient with frozen shoulder? Any ideas out there? So I'm stuck. My motion limitations. Andrew's got limited range of motion. Jessica's got range of motion. Peter, decreased accessory mobility. That's what I'm talking about. Check accessory mobility. Jordan, range of motion, accessory mobility. Mobility deficits. Doesn't matter what part of the body it's in. When you hear the patient telling you about dysfunction in their life because they don't have enough range of motion, in my mind as a clinician, I'm thinking I need to check active and passive range, accessory mobility, and the muscles that cross the joint for tightness, because they may be limiters too. And of course scapular mobility, but we're digressing, we're going to another joint. The point I'm trying to make is mobility deficits, when you hear this type of problem, when you think about the different pathologies that you're learning about in the different joints, The ones that are associated with loss of mobility, patients complaining of loss of mobility, you put it into this rehab category called shoulder pain or hip pain with mobility deficits. And you go about doing your exam. That's what your exam's for, right? I'm going to assess your mobility, active, passive range, and accessory mobility. And then when I find those limitations, I'm going to do mobilizations. I'm going to do whatever it takes to improve your mobility. From there, my therapeutic exercises, which may be in a different course for many of you. In our program, it's all linked. We teach therapeutic exercises right after we teach the manual therapy. Your choice of your exercises is primarily to improve motion, right? Improve motion of the joint and to restore pain-free motion. I mean, that's what we do as movement specialists, right? So think about that. Pain, whether it's neck pain, stiff neck with mobility deficits, or lumbar spine pain with mobility deficits, or knee pain, or elbow stiffness, right? Elbow pain with mobility deficits. Your examination, you've already learned it. You know how to do it. Accessory range, accessory mobility, active and passive range, and your interventions are to improve that mobility. Okay? So, you guys, that's one guideline covered. There's a hip pain with mobility deficit. There is back pain and neck pain with mobility deficit. We've covered it all, right? And these patients, though they may present a little bit different, you already have in your mind what the guideline says about examining patients with mobility deficits. Regardless of the joint, they follow the same strategy. So, when you guys have that as you're going through your orthopedic class, I want you to always think about, I wonder if this pathology fits that category, because then I know what to do with it. I know how to examine it and how to treat it. Now, what I want you to see here on the board, over the next few weeks, we are going to cover a few more categories. Now, is that backwards again? Let me do it this way. Yes, now we can read it. That's much better. Okay, so what's up, Jess? All right, awesome. So what you see is we're going to cover mobility deficits. Next week, we will have a movement coordination impairment type patient. We'll have radiating pain. That's related to nerve root pain. And then related pain, some referred pain. And then we'll talk about related cognitive and affective tendencies. That will cover all the low back pain categories, right? So week by week, we're going to cover each of these pain patterns, and then we'll go joint to joint and start talking. So next week, we're going to talk about lumbar sprains and strains. I'm going to put that back here. Next week, we're going to talk about lumbar sprains and strains. 70% of the patients coming in have lumbar sprains and strains. Don't you want to know how to observe their movements, do the right test, and train these patients who commonly have very easy problems to fix? Don't you want to know that strategy, that rehab concept, so that you can help the 70% of people coming in with low back pain? All right, so in these last few minutes, I just want to open it up. Any questions that you guys might have related to mobility deficits? And in this case, this is back pain with mobility deficits, right? So I'm going to just open it up for a second. You guys did awesome. That is how you do pattern recognition. The simple problems, you have to have a clear concept of how to examine them and how to treat them. And when you have the key patterns that you can recognize easily, then the more gray patterns, the in-between patterns, oftentimes are just overlapping type problems. They're overlapping patterns. Someone with a mobility deficit that might have radiating pain down the leg, right? A combination of two. So I'm just going to open it up just for a few minutes here as we're closing down. Any questions from the team about patients with spinal arthritis? So back pain with mobility deficits encompasses a number of pathologies. Spinal arthritis, degenerative disc disease, right? Facet syndrome, facet hypertrophy, okay? all of these fit under potentially mobility deficits, patients presenting with loss of lumbar mobility. Any questions from the team here? Okay. Well, it looks like everybody's doing good. I'm looking forward to playing out next week's pattern with you. Invite your friends to join us online, and I hope that as we go through each of these patterns every week, what will happen is you'll be able to assign techniques, tests, therapeutic exercises, modalities. All of these will come together and will be associated with the pattern so that you can go out into the clinic, so that you can watch patients and how they move and be able to basically classify these patients properly and efficiently treat them appropriately. All right. You guys are awesome. Thanks for the feedback. More bells for you. And remember our motto for our Name That Pattern Live. We're going to banish chaos and get smart together. Thank you guys for joining in, and we'll catch you next week. This is fun, and I'm glad you guys are hanging out with me this evening. We'll check in with you guys later, okay? Take care, gang.